they have with their EMR documentation and wanting a better work-life balance so they're not spending hours afterwards catching up on documentation when then spending their whole day with patients. I will confess, I used to work at Epic back in the day, and back then it was trying to get folks to use the EMR, and now I'm really trying to focus on getting them to not use it and be more patient focused. And so we went with looking at a solution leveraging ambient technology to record patient appointments when the physician is interacting with the patient and start to generate that note and documentation for them. There are a lot of solutions now expanding in this market. However, we did, as I mentioned, partner with Nuance as part of our strategic agreement with Microsoft. So for those that aren't familiar with Nuance, have people heard of the term before? Sounds like some head nods. Essentially, they are the company that produces Dragon Medical One. So that is the dictation tool that our physicians currently use. One thing I like to remind myself is that, we're not just the only clients. They have 10,000 worldwide. So they are very good at natural language processing, more than, I think some of these startups can expect to be out of the gate. So that was a really big plus for us picking them in the first place. And then they recently got bought by Microsoft. So again, we were able to, through our strategic partnership, get access to a lot of Microsoft's new innovative solutions that may not necessarily be on the market. And then Nuance being in their healthcare portfolio, they were able to come to us before this product was available for others to use to get our physicians' feedback firsthand. In addition, because it is leveraging generative AI to create that note, another added benefit is Microsoft, as you might already know, has a great big partnership with OpenAI, which is the leader in that the GPT-4 model that is leveraged by the DAX application. So here's just a quick overview of some others on the market doing similar things. I will say out of the gate, Abridge is probably the other one that we have, on our radar as a up and comer and that we're keeping an eye on. However, given that we already have the infrastructure in place and they were offering us a free pilot, essentially, we chose Nuance over Abridge for the time being, and we'll see how. So at a very high level, so I'm going to spend some time explaining what DAX is and then where we're at with the pilot and some lessons learned, but happy to open it up to any questions at the end and go back to anything as we get through this content. So at a high level, the physician is going into the patient exam and talking to the patient, but also recording it as well. So the solution has to be really good at leveraging ambient technology solutions, which Nuance is, that can reduce that noise, the background noise suppression, and really focus in on like the voices that matter. And then it leverages conversational AI, which helps distinguish one voice over the other before then ultimately generating that note from the transcript. So what does that mean from like a practical perspective? We realize, we can't just go recording all this like patient data without, getting very specific consent. So especially in the state of Illinois, we have very strict eavesdropping laws. So just recording a patient's voice, even if they're not saying health information, just their voice alone could be a potential felony if we don't have their consent, which is why we have stricter processes in place than other clients that only support verbal consent. We have an actual documented consent workflow in Epic that our front desk supports when a patient comes into the appointment. They explain the pilot, they get their consent, it's documented in Epic, and then through the office-specific workflows, they will let the physician know. So for example, some of our practices will add a checkbox on their rooming sheet so the physician knows, like, yes, it's safe for me to go ahead. This patient has consented. We are working on better ways to automate that notification to the physician, but as it stands, this is where we're at. Once the clinician has, understood, yes, it's okay to record this patient, they will pull the DAX app on their phone. It's actually now been released to the public. So it's baked into their Dragon tool. So it's very clever advertising, in my opinion, that anybody who's a Dragon user will now also see this button for Copilot that they can select and start the recording. Each recording, you can have multiple recordings per one patient. So if you're a physician that likes to say pre-chart and load all their patients for the day, you have the option to do that and then add to it as you meet with the patient, post-appointment, if there's any follow-up. So you can keep adding those recordings to a patient summary. And then what DAX does is it generates a note in a very standard template. So for example, there's a section for the HPI versus the assessment and plan. And then the physician has the option to copy and paste when they're at their desk in Epic, those sections from the DAX generated note into their actual note. We are working with them now on exploring ways to better improve that integration even more. So we'll have hopefully some exciting news about that in the next few weeks, but really trying to make it as seamless as possible for our physicians. I have a video we can share from Nuance, if we're doing all right on time. Okay. And this link also has the more materials from Nuance too, if there's other videos and information you want to hear about it. Megan, I might need your help to get this back. Oh, here we go.
Introducing DAX Copilot, your AI assistant for automated clinical documentation. Formerly known as DAX Express, this new addition to the Dragon family relieves administrative burdens to increase clinician satisfaction, improve patient experiences, boost operational efficiencies, and achieve financial outcomes across specialties. This industry first combines proven conversational and ambient AI with the most capable generative AI, amplified by the power of the Microsoft Cloud for Healthcare and Azure. Using a secure app or supported EHR mobile app, DAX Copilot captures the complete patient story. And in seconds, converts multi-party conversations into structured and specialty-specific clinical summaries that are immediately available for review and editing. Clinicians can view and access all available clinical summaries in the app or directly in the EHR. Using just their voice, clinicians can tap into a full suite of customizations, templates, and shortcuts that allow them to personalize their notes using Dragon Medical One's advanced speech capabilities and time-saving EHR workflows. As part of the Microsoft Cloud, DAX is delivered through a trusted, reliable infrastructure and global platform, guided by an established responsible AI framework and core set of principles. It's secure, flexible, and scalable, and the results speak for themselves. Better work-life balance, higher job satisfaction, greater documentation quality, and more focused, personable, and conversational patient visits. With DAX Copilot, automated clinical notes are just the beginning.
Kind of gives you a sense for the workflow there as well, and the interface of the actual DAX app. One thing that did not highlight, but you might have seen, is you also have the option to view the transcript of that recording. And that's been one area that we've gotten a lot of feedback, has been beneficial for folks to just take that cognitive burden off of them of having to remember what a patient said in one visit when they've got 20 patients throughout the day. So just even having the summaries or the transcript available to jog their memories has been one of the key benefits that a lot of folks have voiced to us. So just a quick summary on where we're at with the pilot and some of our lessons learned, and then I'll open it up to questions. Essentially, we kicked off this iteration of DAX on September 19th. We had almost 15 physicians in one location at the GIM clinic down here, and then we have since expanded to 50 physicians overall. 25 have been onboarded and 25 are in the process of onboarding that we hope to get live in the next 2 weeks. So while we were primarily focused in primary care, DAX or Nuance has opened up those specialties to a smaller Still not all specialties, but some. So there are areas like orthopedics, cardiology, our immediate care areas that we're experimenting to see how does this tool benefit those physicians. And then we are also collecting both quantitative data through our EPIC signal data. So for those that are familiar with EPIC signal data, it is basically a summary of really discrete metrics that we can get to as far as how are physicians or clinicians spending their time in the EMR. Are they using, or how many minutes we can get down to on average in a note versus, their in-basket. So we're using a lot of that quantitative metrics, but then we also couple it with qualitative metrics. So we are serving physicians for their feedback, getting some ideas for future benefits or features we want to help them push Nuance to develop. And then also we are looking to meet with leadership to determine, now that we've collected all this information, or when we will in January, is it worth the cost to scale? So we have a specific framework that we do that through our innovation team. There are essentially 4 domains that we look at for any of our IT solutions. So really understanding overall, yes, is this helping the physician's experience, or is it just shaving off seconds that it doesn't matter as much, so we're going to zero in on that. What we have interestingly noticed is actual improvements in our patient top issues for certain clinics. So for example, communication might have been listed in some of our clinics, and it's no longer there for the ones that we've piloted. So we've also already seen an uptick in patient experience as well, because they're having that more conversational meeting versus being glued to their computer. And then revenue capture. If we're reducing that amount of time that physicians have to spend in the EMR, does that free them up to take on more ad hoc appointments? So we're going to be looking into that to see, can we essentially pay for this tool if it's something that we see organic growth in our improved access. So lots of metrics we're going to be taking a look at. Happy to give an update later on, but definitely looking to see what is the value this tool is actually bringing, because it sounds nice in theory. We want to make sure that it's actually benefiting our physicians. So real quickly, some key lessons learned. As I mentioned, consent is so critical. It's been really an essential part of this workflow in any pilot we do when it comes to ambient technology solutions. We have experimented in this space already, so we did have, templates that we could follow and workflows that we could build off of, so it wasn't starting from scratch, which was really helpful. As I mentioned, we are exploring with Nuance better ways to integrate with the EMR. So they are about to publicly announce the availability of having Haiku integrated with it. So I'm not sure if any of you are familiar with Haiku. I'm seeing some nods here. So that way you don't actually have to have a separate app. Instead, you could use Haiku, select the specific patient, start recording for that appointment. And then what will be nice is that there'll be smart links that can be embedded into the physician's preferred templates to say, if they are the kind of physician that only likes the HPI, they can just put that HPI smart link and it'll automatically pull it in for them versus having to copy and paste and spend that time. So some key benefits there. Another item that's going to be, I think, really big for that integration is right now, in order to train the AI model, the physicians have to make their edits in the DAX app. I guarantee you nobody is doing that. Everybody is editing their note in Epic, as they should. It fits their workflow. But with this integration, the edits they make in Epic will actually be downloaded and compared and then reviewed for to be trained in the model. So really hoping to see a jump in the improvement in the notes that are generated based on physician preferences once we have this integration. And then, as I mentioned, the cognitive burden has been really interesting to get feedback on people just being like, oh my gosh, such a big weight off my shoulders, not having to think through all these appointments. And then, as I mentioned, the communication between patients, I've heard anecdotally from a lot of physicians, the patients have been, pretty open and enjoying it. Very rarely we'll get, people who decline the consent. Usually those folks are lawyers or potentially other doctors, but it's been majority folks have been saying yes to the pilot. So I know there was a lot of information at once. do you want to open it up for questions if people have them?
There are a couple questions in the Q&A. If you want to open up the Q&A.
We'll do the in classroom first.
Hi, thank you so much for an awesome presentation, and this sounds amazing. I have two questions. One is, how can I get involved in a pilot today? And then secondly, I primarily work in the ICU, so most of the information is all on the ground, and have you guys explored how it works? Because there's like a resident, insurance, pharmacist, many more voices on ground, and there's a much more complex discussion and a lot of back and forth. Have you guys explored recording that and writing the research for people like me who and all the other information as well? That's like a very, very rich discussion.
That is a great suggestion. I know Nuance in general is exploring the inpatient space, so we'll definitely take that feedback to them that potentially rounds is a great way to capture. As far as your first question, just hopefully my contact info will be shared. Feel free to email me. We do have a wait list of folks that are interested and absolutely happy to add more, especially as we look to think through, like, is this something we want to scale? If there is a lot of interest, that also will help sway leadership. So feel free to reach out to me. And then separate from this, we are also exploring another inpatient potential use case related to nursing and flow sheet documentation. So that is very, very much in the pilot stage. There's not even like a real product out in the market right now, or they are just right now working with our team to work with our nurses to collect information about what that workflow would look like. But I can definitely ask about the ICU ones. And I apologize, I don't think I repeated the question, but it was essentially related to ICU suggestions, around suggestions.
Do you anticipate if this were like more widely deployed that the consent will persist as a written mechanism, or is that like possibly just a very cautious interpretation of the law that could be changing like that in practice, or like kind of general consent decree?
My dream is that we can eventually bake it into the universal consent that we have to collect for all patients regardless. So really it's understanding, once we get out of this pilot phase, that yes, we want to keep it make it stick around, and working with our legal team to see how can we include that in our universal consent, that it is an obvious one and we don't have to go through this separate process.
What are the voice recordings retained, or are they ones that transcribe like the audio?
Yeah, great question. So from a physician perspective, it's typically archived after 30 days. And then from a Nuance perspective, they keep the transcripts, the audio files, they delete after, I think, a year. And then the transcripts to train their model, they use that for, I think we have a contract with them to only keep for 3 years. So, yep, go ahead.
And will the recording be used to retrain or fine tune the model? And even if just before Northwestern medicine only?
Sorry, can you repeat the question?
Will the recording be used to fine tune or retrain the model, even if it's just in the context of Northwestern medicine only?
So I believe the question is, are the recordings used to just train Northwestern's data versus all their other clients? Is that the question? Yeah. So my understanding is that they do use a percentage of it to help with their specialty focus. So essentially there's a different model for like primary care or for, cardiology and things of that nature, but it is a more collaborative space. And that was why another reason it's why we went through so many data security rounds with them to review that. Okay.
The positioning needs slightly before the flinch, but that would talk about that. We capture like we use it to get people to do more work. Has there been any kind of systematic discussion about how this could actually be used for quality of life and like not?
Yeah. Absolutely. All things are on the table at this moment. So, when I say revenue capture, we also look at like turnover metrics, right? So if your physicians are leaving because they're being burnt out, there are studies about actual dollar signs of what that could be from a revenue perspective. We keep them here because they're happy and they're not using. So different avenues we could take. Leadership has not made a decision one way or the other. The only decision that's made is that we need more data. Since we started this in September, we only really have like October as a solid data month. We need at least 3. So we are working on extending the pilot until end of February so we can capture more data and work with leadership to define what does that look like if people want to use this tool or not moving forward.
I would actually have their like DMR usage monitor to see like how well they document the notes and actually track those.
Yeah, exactly. So that's where the Epic signal data comes in, that we can really look at what is called pajama time. So how many hours are people spending outside of their work hours documenting? We want to help reduce that. In fact, we found out of our high utilizers already, like those that there's some that like spend, you know, way more than 2 hours on their documentation. And those are the folks that, you know, have been gravitating to the tool. Oh, sorry.
Online is asking.
So a quick question regarding the specialties that you guys choose to pilot this program with.
Mhm.
How are those specialties chosen? Is it all related to that retraining process that you were talking about?
Great question. So the question was, how are the specialty chosen? Easy answer, Nuance told us. So when they came to us with the pilot preview, not publicly available to everybody else, they were very specific. We are primarily focused on primary care. So internal medicine is acceptable, pediatrics even, but really wanting to just focus on that area. They have since, and this is one of the benefits, I think, working with a large partner like Nuance, is they have evolved so quickly over the past few months, right? So they came out with new specialties about a month ago. So that's where we were able to add ortho and cardio. And then in January, they're going to be releasing some more. So there's potential to expand to those.
Very cool.
Yeah.
I have a follow-up about that.
Yeah, go ahead.
So on the transcription front, so on the actual mobile app, does that happen offline or is that an online process?
So in order for the app to work, it has to be connected to Wi-Fi, period. And you can access that same note transcription using the blue flame icon in Epic. So you can see the transcript on your desktop as well.
Maybe we should go online real quick. I think Prashant had his hand up.
Yeah, there's 3 in the Q&A. Yeah.
Oh, no, the Q&A.
Yep, Q&A.
So I see some questions here. So there's a question related to generating structured data from the notes. At this time, there is not any plans for that. However, I know they've talked about it in their future roadmap. So obviously we've collected feedback from our physicians, like, while it's great to have your notes, what are the next features you want to be able to improve or automate? And I know orders has come up a lot. So really, I think working with Epic is working on some ways on how to automate this based on the partnership with the integration. So I think there's definitely going to be more of that coming in the future, but in this current state, there is not. The question about VR, AR and VR here. Yeah, feel free to email me. I can put you in contact with Sal Grasso, who's been spearheading our AR, VR work there. So we've got some HoloLenses and use cases we're trialing. So happy to have him come here and share if that's of interest to folks. And if you want to reach out to me, I'm happy to put you in touch with him. And then there's a question related to, I wonder if you can let us know more specific about terms of service, especially regarding these vendors do with patient information. So similar, like what I said before, we do have a very strict data retention process with them. They can keep the audio files for a year and the data for the terms of our contract, which is the overall Nuance contract, which is good for another 3 years. Any other questions? Although I know I am going over time. All right. Well, thank you everybody for letting me present today, and happy to follow up with any other questions you have.
Thank you, Anna. The demand is high.
Well, actually, I think the questions, one of the questions sets up the stage perfectly for the next presentation. So the question was, were there any utilities for converting and generating structured data from those large language models, right? And so in the next work that we're gonna hear, It's based on leveraging large language models to revolutionize data interoperability in the healthcare industry, and in particular to generate HL7 FHIR resources automatically. And it's actually from my student Yikuan. And so I'm not a person that's shy of self-bragging, and especially it's coming from my own student. And so FHIR-GPT streamlines the entire process of converting the clinical notes into the HL7 and FHIR medication statement resources. And the implications of this utility is profound, because for many industries like pharmaceutical companies, it promises more efficient data utilization and seamless integration. And for health insurance companies, it can anticipate enhanced claims processing and risk assessment. And for hospitals like us, we can benefit from improved patient care and streamlined administrative processes. And without further ado, I'll introduce Yikuan. And Yikuan, please take the stage, and I will hear from the FHIR-GPT. That's going to be the next presentation. Thanks, Yuan, for the great introduction and having me here. And so my name is Yikuan. I'm a 5th-year doctoral student in the Health Sciences Integrated PhD program. And so this study was conducted by me, my advisor, Dr. Yalo, and some of our life fellows and industry partners. So let's get started. So I think there are 3 keywords about this study. The first is GPT and FHIR and the interoperability. And FHIR-GPT, everybody is using it right now in research work, daily life, so I won't cover it too much. But what is interoperability? So here's the definition by HIMSS. It's the ability of different systems to access, exchange, integrate, and cooperatively use data in a coordinated manner. So basically, it's trying to solve the problem, like to exchange data between different hospitals or health systems. So right now, there are many different vendors for the health information systems. Some use Epic, some use Cerner, but they have so every hospital has their own dialect or accent in how they organize the data. So I was involved in a couple of different projects that want to collect the health data from different sites and merge them together to build a larger data set. And one is to make our own data to conform with the format of Beth Israel, and to make like a next version of Mimic. And Yuan has the critical, which is use the common data model, and it has Capricorn. I don't know what you use for that, but it's a pain, like because different hospitals are using different data, and if just one piece of data in one hospital is just one row in the table of the in the system, but for another hospital, we have to look up a bunch of different tables to populate the information. So basically, so input interoperability can help smooth the process of exchanging and integrity data. And so there are some other benefits for the research. It can be used in phenotyping and public health surveillance, and to solve the health equity. And there are so many different benefits. So this is interoperability. And what is FHIR? FHIR is short for the Fast Healthcare Interoperability Resources, and it's kind of a standard that used to exchange the EHR data. And I'm going to show you an example in the next couple of slides. And so basically, you can convert your EHR data to the FHIR format. And so by doing this, people can exchange and integrate data together. And many federal agencies, the Office of National Coordinator for Health Information Technology, CDC, and Center for Medicaid and Medicare Services have been working together to promote adopting FHIR to improve interoperability. So I'm going to show you an example of, this is just one piece of EHR information from real-world patient about hemoglobin. And it's in the observation table. You can see there is a nested JSON data, and it has many information. It's from observation table and the log code of hemoglobin measurement, I guess, and the patient number and the caregiver number and the value and interpretation and reference range. So it has so many different information. And HL7 provided a very comprehensive and detailed description of how the observation table should be organized. It contains data type, cardinality, the description of table, and so many nested structure that it can be used to populate this table. And if you follow this structure, the data from different sites can be merged and used together. And let's go back to the slide. So there are many directions in the FHIR conversion from EHR data to FHIR. So one is what I just is just from observation table to the FHIR resources is the direction of tabular data to FHIR, and another direction might be the inner loop of FHIR to FHIR, because right now we are in the 6th version of FHIR. There are some historic version can be used to upgrade to the current version, and there is the international standard and then US standard you can probably convert from each other. And so for this study, we are only interested in this direction of conversion. So it's from textual data to the FHIR resources. So the input is textual data, clinical notes, pathology reports, radiology reports, and the output is the expected FHIR resources. And I would like to say this direction is the most difficult one because you have to identify the key information from the clinical notes, and but for structured data, it's relatively easy because you just look up the table, find the correct information, and feed them into the schema or the structure. And let's go next. And here's an example of types of FHIR. So the input should be just a sentence in the, let's say for this is the discharge medication instruction, saying 8.6 milligrams tablet, 1 tablet per hour, 2 times a day as requested for constipation. And if we convert it to the FHIR resources, you can see this long paragraph with so many different information. They have dose, strength, route, timing, reason, and concept codes associated with those elements. So this is an example. So we want to complete this process of conversion using different methods that I will cover in the next. So what we are doing right now, so one way is to do the human annotation, or we can use some NLP tools. The NLP tools follow the process of our human annotation. It's a multiple step process. So the first step is kind of considered as a named entity recognition task. We have to identify the entity of each word, or in the sentence, let's say the first one is a medication and tablet is a form, PO is a route, and constipation is a reason. This is the first step to identify the entity from the sentence. And next step is to find the relation between the entities, because in one sentence there might be more than one medication has been mentioned. So we want to figure out if this one, the route is associated with the medication for percent. And the third step is standardization, because it's in the clinical notes that there are too many ways to express just the idea of using through mouse, per hour, PO, P dot O dot, and there are so many different combinations. So the third step is standardized to oral, and the first step is just look up tables for the unified concept codes. For this one, we use Snowman, but there are too many options. You can use login codes, UMLS, and for different tables, you can use different codes. And the last step, there might be a fifth step of calculation, but not for this case. But if you are interested in timing, like say if you distribute 10 tablets and the frequency is 2 times day, some simple calculation are needed. Let's say the duration is 5 days, so you just divide it 10 by 2, right? So there might be some simple calculation, but we skip this for this case for just the route. And here's the final expected output just for the route of this case. And because there are 1, 2, 3, 4, 5, 6 steps for just generating this FHIR structure in both the existing NLP approaches and our human annotation. So what are the drawbacks and limitations of this approach? Human annotation, basically intensive human efforts just while for that one sentence, you have 5 steps. And the existing NLP approaches, you require massive training data and resources, and it might not be that accurate. And the generalizability is a question. So we have to train a new model for every single table. And if, let's say, there are some upgrade of the FHIR resources, we have to retrain the model or do some fine tuning. And also for different code size, we also need a new model. So the generalizability is low and high maintenance costs because there are too many components. You have, if the model makes a mistake, you have to figure out which part of the model makes that mistake. And so our idea is to streamline this process with just one step using generative AI, FHIR-GPT or large language models. So the input is text, the output is text. Why don't we just use large language models? And so this is basically the idea to enhance health data interoperability by standardizing contextual health data to their associated FHIR resources using large language models. We call it FHIR-GPT. And here are the technical part of this study. So right now, there is no large public available data set that contains both the input and output of the pairs of data. So and so we decide to manually annotate a data set that is about medication statement resources. So why we chose that for many reasons. The first one is our annotation was built on an existing annotation, which the clinical experts had already done the anti-recognition part, so it makes our task easier. And the second one is there are many key information, especially for the medication, they are carried in the clinical notes. Let's say the dosage instructions or the frequency, you may not find it in the structured data. So that's why we are interested in the medication statement table. And it contains so many different information, dosage schedule, reason, form, route, strand, and it's sourced from an existing human annotations of the National NLP Clinical Challenge 2018. And here is the workflow of our study. There are probably 3 different branches. The first one is annotation. As I said, we built on an existing annotation and continue. So the first step has already been done. We did the steps 2 through 6 to get the FHIR resources. And another approach is using the existing NLP approaches. And there are 2 mature products in doing this conversion. One is called NLP to FHIR. This released by Melville, and another is the Google Health Natural Language API. It's a commercial product. You have to pay for service. And another approach is using large language models, and we feed in the prompts and the input into the large language models and allow them to generate the FHIR resources. And we are interested in 3 different language models. The first one is GPT-4. Second one is Llama 270B. It's released by Meta, Facebook. And third one is Vulkan 180B. It's released by some UAB folks. That is the largest open source large language models I can find for this 180B model. But it doesn't have a commercial use license. But for Llama 2, you can use it for commercial purpose. Slightly different. And so what's the prompts we use? So due to the token limits of the large language models, you can't put in the whole book just into the prompt, right? So we have to split them into 5 different prompts, one for medication form and strength, another for reason, one for route, one for timing, and one for dose. And all 5 prompts follow the same template. The first one is a simple instruction of what the tasks are. And the next is the template, which just directly copy from the FHIR resources, their white book. And the third one is the examples. We provided a couple of different examples. So we are using a few short prompts. And last one is the terminologies. For here, here is an example for route. So there are 147 routes in the STOMAP table, and we provided a whole list just right here. And so large language model can choose from it. There is no training process in this study or fine tuning. We just did it using a iteratively trial and error. So we have a small subset and we try different prompts and to see the results and refine the prompts by repeating this process to improve it. And there are slightly differences in terms of different large language models because they are sensitive to different words and we have to make some small modifications. Here it comes to the results. This is the results of the annotation. So basically we annotated 3,700 pairs of free text input and the expected output, and they covered 280 different admissions, and they are about this number 1,700 different medications, and the availabilities of different elements might be different. The reason is the smallest, about only 1/3 of all the pairs mentioned what's the reason of taking this drug. But for some other elements, let's say the timing is over 60%. And this is a annotated data set and massive effort from me and our collaborators. So we plan to release it. Here is the results. And so for the left part are the results from large language models, and the right part are existing NLP pipelines. You can see some black here. So that's because the existing models did not cover every details of or every elements of the resources. We have just to leave it there. And but for other three large language models, GPT-4 did the best job. It achieves an exceptional accuracy, or we call it exact match at every single element, and it's over 90% accuracy and outperform the existing method by a lot. And we also observed there's a trend that GPT-4 has around 1.7 trillion parameters, Vulkan 180 billion parameters, Llama 2 70 billion parameters. So the larger the model is, the better the performance is. And that's provide a foundation that we can use large language models to generate the file resources, and is doing a better job than the existing models. And those are the advantages of our large language models or FHIR-GPT. No training is required, improved in accuracy and efficacy and flexibility. If we are interested in different tables, we just change the instruction, change the prompts accordingly. And some limitations and the future directions of this study. So right now we only focus on one resource, but for FHIR they probably have 20 or 30 different resources, and we plan to expand on this. And also all the data resources are from that data challenge, essentially are from the mimic data set. So we may be interested in some other data set if we have the benefits to annotate more data. And here is the QR code for the preprint and our email address. If you are interested, just reach out. Yeah, that's pretty much it. And I'm open for questions. Yeah, Jenny.
Thanks for a great presentation. So you mentioned something about prompting, and you have to do like modifications to the results, and prompting is really big. I'm trying to what are some of the like, oh, depending on what you're trying to extract, or any nuances you want to do.
That's a great question. Yeah, the question is like, what did I do for prompt engineering, right?
Yeah.
And so basically just iterate to the process, and I found some interesting patterns. First, provide more examples, really helpful, like cover every edge cases. And secondly, use some strong words. Let's say you must output follow the JSON format. And third, I found sometimes there are some inconsistency. If you improve on the small subset, but in the final, let's say all 3,700 cases, it's not over the case. And also, I found there are some mistakes of the large language models. Let's say they are trying to cater people like by generating some makeup codes for that is not even existed in the SNOMED code set. And also there are some mismatch I have to figure out use some strong words, do not make up any codes, if just leave it blank if necessary.
One of the techniques that can help with preventing those hallucination problems is to use the knowledge graph as a guidance to those large language models, so that will stick to the knowledge graph content rather than thinking freely on itself.
Yeah, thank you for the suggestion. We can just suggest using knowledge graph to improve this.
On that note, doing something like chain of thought reasoning or step back reasoning can help it follow the knowledge graph a little bit easier. Has there been, sorry, I actually had a question.
Yeah, go ahead.
With your new license of 128K input tokens for GPT-4, have you considered any updates to your prompt engineering, and has that resulted in anything better for you?
That's a great question. Question is about with the new release of the extending the GPT for token limits for the input. Do I have a plan to upgrade this result? Yes, I do have that plan if possible, but GPT-4 is expensive. I like to say with the longer prompt input. So yeah, we have to make some compromise. Yeah,
it can cost you up to I think $2 for a call if you do the 128K, but which gets really expensive when you're doing 3,700.
Yeah, exactly.
Yeah. So totally fair. I had another question regarding GPT-4B in particular, and so by my understanding, so the one of the primary purposes of this is introducing this interoperability standard. And at least from my limited experience in the clinic, often what you get is a stack of faxed paperwork that includes a lot of tables that could be converted into FHIR standard, but really all you get is images. And so I was curious to know if there's been any thoughts on multimodal approaches here or OCR to convert it to text and then do this pipeline that you built. How you would handle something like that.
The question. The question is about if we have a plan on expand this to multimodal learning. Let's say if there is the input is images, or are we plan to do OCR or just integrate the image as text? Yeah, answer.
Yeah, so I think that's a good question. And another research faculty in my group is doing the knowledge graph based training, so that it can do contrastive training using image and text for now. But we are planning to expand it to image, text, structured data, and molecular data. So that with this multi-model cross training, you will be able to generate a coherent representation at the language level to integrate all those data sources. And it's guided by knowledge graph, meaning that it will combine to the current knowledge without being hallucinated across the much model. Yeah, so we had a paper that is under review, and then we're also expanding on that paper. Not yet online, but probably in the next month or two we can do it. That's difficult. Yeah.
Please, very nice results. You may want to think about the new model Quen 72 custodian that came out as Yikuan, which is approaching GPT-4 performance on a wide range of tasks at 72 billion. So you might want to just kind of explore that. And then, it's one of the advantages obviously of having local models is you can actually differentiate between two other things. And so going back to this sort of prompt engineering discussion, there was a really neat detail in one of the Metacom papers where they actually, I think it's multimodal one, but they used they would basically optimize the prompts directly as a way of fine tuning that was really parameter efficient, and might be something you could actually directly explore if you haven't modeled it. And I guess, then if you end up in a situation where you're data limited, then one of the beauties of what we're doing, you can also go the other way, right? So you can start with FHIR and create synthetic actual descriptions, and that approach of taking structured data, creating synthetic data is being really effective in some kind of creating some medical and
exactly. That's so the question is about, sorry, it's not a question, it's just suggestion. It's one of us trying a new model, and it's only 70 billion parameters, but comparable to the GPT-4 model. And I will try that. Thanks for a great suggestion. Another is do a paper about prompt engineering. And third is the suggestion do the reverse way. We have there are many FHIR resources on the market, and we can use it to generate the silver standard original nodes and use it to do this process back and forth to improve the performance and we have discussed with them about this approach, and we probably will do that in the next step. Thank you.
Yeah, first of all, really exciting work, and personally very curious why you've chosen the two-shot approach, and if you have also considered to fine-tuning of the existing open source large language model itself to really tailor the domain of the large language models more into exactly this task and to potentially choose that.
Thank you. The first question is about why we chose few shot prompts approach, and we did try some different combinations to use. We also tried zero shot. The performance decreased, but still reasonable and comparable to the existing approach. The second question is about fine-tuning not just use prompt engineering, but fine-tuning the model. And we also tried it as well. But the thing is, you can see the model right here. The smallest is 70 billion parameters and need massive training resources. And for the OpenAI GPT-4 model, we cannot fine-tune, or at least in cost of all. And so we did fine-tune the Llama to 13 billion models, and the performance can increase, but the problem is for the fine-tuning, we cannot fine-tune every single models. Also, the one advantage of the large language models is that no fine-tuning is required. Is still gives a really good result. And if we don't fine-tune the model, the generalizability of the model is good. If we are interested in different tables, we just change the prompts and no fine-tuning is needed. So, but it's kind of a balance between whether we should fine-tune it or not. And it's good if we have a local model and just tailor it for our, let's say, Northwestern data, and the performance is really good, but it might also lose some generalizability. Yeah. Any questions? I don't know if there's question online.
Another one.
Yeah.
So for one of the tasks, you are annotating code, like common code within these results in FHIR result. Have you considered, or do you provide some terminology in the prompts already? Have you considered using API calls instead to more generalize the code or the ability to encode different concepts instead of only providing a limited list?
The question is to replace by not doing append a list of different terminology codes, but using API calls to do the encoding part. That's a good suggestion, but I think before that we have to do the standardization, right? And for the encoding, if you just do API calls, I know there are some products of even Snowman International, they have such function, but that is still kind of a two-step process. But if we just use large language models, it's just one step. Thank you, everyone.
I think we're good. All right. So just want to thank everybody. This is like a nice diversity of presentations today. I think we heard a direct clinical use case, and then one I think that I was very excited to hear about the interoperable use case.